Hello, everyone, and welcome to Right Upper Quadrant 411. This lecture is for the students specifically approaching emergency medicine and what you're going to do when you have a patient with right upper quadrant pain. Obviously, this is one of my older lectures, and I do apologize for some of the organization of this lecture, but we're going to get through it, and hopefully I'll have a chance to redo it in the next several years. So, when you first approach a patient with right upper quadrant pain, the first big question you got to ask yourself is, what structures are found in the right upper quadrant? What could be causing this patient's pain? And so, there's actually quite a lot of things in the right upper quadrant. Notice that there's the liver, there's the gallbladder, there's the large intestine and the small intestine. There's the head of the pancreas, as well as the biliary duct system, as well as the pancreatic duct system, as well as part of the stomach. There's even the lungs. The right lower quadrant of the lung is located there. What about the ribs? What about a whole bunch of blood vessels? What about a whole bunch of muscle? There's quite a bit here that could be causing right upper quadrant pain. So that means that we need to get more information. We need to try to assess the risks and the clues that are helping us to narrow down what is causing this person's right upper quadrant pain. So I've listed quite a few here, but we need to ask questions about the patient's alcohol use. We need to ask about diabetes. We need to ask for risk factors on gallstones. We need to try to figure out whether the pain is constant or intermittent, whether it changes if you take a deep breath, whether it changes with eating. Does it feel better or worse? Is this person somebody who looks sick? Do they look jaundice? Have they had fevers? Does the pain change with movement or twisting? There are a lot of different factors and details that can help you narrow down where this patient's pain is coming from. Now, the most complicated part of the right upper quadrant is always the biliary tract. I think students struggle with this the most, so I'm going to emphasize this most during this lecture. So both of these pictures that I have presented here are both representing the exact same thing, which is the biliary tract or the anatomy of the biliary structures. So notice that this is something that you could very easily practice with drawing. And I would recommend that if you get easily confused during this process, or if this is something that you've struggled with quite a bit, you practice drawing these structures over and over and over until you start understanding the differences between the different disease processes. So notice here that we're going to have our gallbladder at first, which leads to our cystic duct. This is the part of the duct that connects to the rest of the duct. The only thing that is higher than that is the hepatic ducts. Now we have the right and left hepatic duct as well as a common hepatic duct. So the liver itself makes the bile, which goes down the right and left hepatic ducts into the common hepatic duct, and then actually makes a big U-turn and dumps it into the gallbladder and stores in the gallbladder. Now, when the cystic duct and the common hepatic duct come together, that is the common bile duct. And you're going to hear quite a lot about the common bile duct a little bit later in this lecture. Now, you also notice that the common bile duct, especially down here, intersects with the pancreatic duct. They become one and the same. Because of this, both of them enter into the intestines, the duodenum, in the hepatopancreatic ampulla, also called the ampulla of Vater, okay? And the sphincter itself, right, that thing that opens and closes, is called the sphincter of Oddi. And a lot of people remember this ampulla of Vater because of Star Wars, and they remember sphincter of Oddi because Oddi is the funny dog in Garfield that gets kicked off the table all the time. If that helps you, awesome. If it doesn't, I'm sorry. The important part is understanding how all of these structures work together, because there are different blockages that can cause different problems in the biliary system. So let's move on and let's go talk about them. There are 5 main biliary diseases, and this is an overview, so don't panic yet. of the different clinical presentations and the different causes. And then I want to go through liver function and the liver function tests and labs and what they mean and how to figure out which kind of disease process that the patient has going on. And then finally, I want to cover just a couple of basic things like Tylenol overdose and Fitzhugh-Curtis syndrome. So let's get started. And the best way I know how to learn these is to present to you a case. So I'm going to start off with the simplest of the cases, and that is two different cases. So on the right side, we have this 41-year-old patient. She's obese and white female coming in with right upper quadrant pain and vomiting. Pain started 8 days ago, then went away, then started again, and it comes and goes. Lasts for an hour. It's been constant. Obviously, you can read, but I got to go through all of this stuff. So the other patient, 43-year-old, has almost exactly the same history. It also started only about 8 hours or only about 3 hours ago and is intermittent without vomiting, but does have some nausea and it radiates to the back, right? It's also associated with eating McDonald's. So the different clues in this history is that both of these patients are tachycardic. Okay. Both of these patients are essentially afebrile. Both of their vitals are almost the same. Notice that the 41-year-old patient has vomiting, whereas our other patient has no vomiting. Notice that the pain with the 41-year-old started 8 days ago and has been intermittent, but the pain with the 43-year-old has only started 3 hours ago. So this one is a little bit more acute. Notice that both of them have intermittent pain with waves, although this one radiates to the back and this one has been getting worse and now is constant. So hopefully that you can kind of recognize some of the different risk factors in both of these. Notice that both of them have had this in the past, but this one says it's different and this one just says it's a little bit worse. Okay. So it's really important to understand the differences between these two processes. So let's talk about the differences in the labs. So you can see that one of these patients, especially on this side, has acute cholecystitis, whereas the other patient only has symptomatic gallstones, aka biliary colic. Notice that the labs are very, very similar. Notice that both of them have a high elevated ALK phos. Notice that both of them have a high T-bili. You're not going to have a biliary problem without a high T-bili. This can be one of your big defining features in these patients. However, acute cholecystitis usually has elevated AST, ALT, liver enzymes, whereas symptomatic chole does not. Notice that symptomatic biliary colic can also have an elevated white count, although does not necessarily always have to, and can be real pain due to, as proven by the tachycardia. However, acute cholecystitis definitely has a higher white count. It has the liver enzyme involvement and does have pain associated with right upper quadrant pain. You're also going to be looking in acute cholecystitis for those signs and symptoms like rebound and pain with compression right in the gallbladder area. So these are very, very similar disease processes, but one of them has findings on imaging and one of them does not. I wanted you to compare these side to side to see how different they can be and yet how similar. So really the main difference here is you're going to end up having to order a right upper quadrant ultrasound because it's very difficult to tell the difference between these two. So let's talk about ultrasound. When you're ordering an ultrasound, you want to order the Ultrasound Abdomen Limited. Okay, these are more sensitive than CT scans. CT scans can see stones, but they may not necessarily be able to see the difference between acute cholecystitis and symptomatic biliary colic. So what we're looking at here in this picture is these big white stones. You can see the stone is right here because it has the shadow this hypoechoic dark region where it's kind of like reflecting down below. So you can see there's another stone, and I know that these are stones because it has this shadow underneath it. And this is how we can tell where the stones are versus the sludge. So let's take a quick look at some ultrasound findings, being that this is so important for the ultrasound, or for the gallbladder, I'm sorry. So we see what gallstones were. We just kind of went through where we have this hypoechoic shadowing. That's really important. If you have gallbladder changes, right, then what we're going to be looking for is we're going to look for pericholestatic fluid, which just means fluid of inflammation around, aka outside the gallbladder. And we're also going to have gallbladder wall thickening because we've got all that inflammation going on. Those are two findings that we're going to see that lead to cholecystitis. Now, remember that these take a couple of days to happen. Building up that inflammation in order to thicken that gallbladder wall and get enough fluid that we can see it can take a few days. So if we're catching this rather early, remember to look for our sonographic Murphy's sign, right? So that's the pain with pushing on the right upper quadrant. That can lead us to the correct diagnosis of our acute cholecystitis. Now, there are other things that can cause thickening of the gallbladder wall and some buildup of fluid. And here are some examples right here. However, your differential is very nicely listed all the way over here. And if you have ductal dilation, right, then that's usually going to be one of the other biliary diseases. So we're going to look for that thickened wall, right, especially asymmetrically thickened. We're going to look for that pericholestatic fluid. We're going to be looking for gallstones or sludge and a sonographic Murphy's. Those are the main four things that you have to know if you're going to be looking at the gallbladder reads. All right, and here are some examples of those findings. You can see right here that we have the stone in the duct. You can see here that we have this thickened gallbladder wall, right? And you can see this here again, thickened gallbladder wall, thickened gallbladder wall. You can also see the fluid located around the gallbladder here. Okay, here's the gallstones with that shadowing that you can see. Here's sludging, and you can see that it's sludge because it has absolutely no shadowing below it. And then you can see this big difference down here. This is the ultrasound, and this is the CT scan. And while we can see the thickened gallbladder wall here, and we can see the sludging that's located in the gallbladder, here you can't really tell whether the wall is thickened, and you can't really see whether there's any sludging or stones. So you can see the difference between the ultrasound versus the CT scan in that picture. All right, so when we talk about acute cholecystitis, this is something I can guarantee that you will see. Think of it as the kidney stones of the gallbladder, right? Because a stone is pretty much formed because the bile has just been sitting in that pouch being stored for a long while. I also want you to notice that you can have an acute or a chronic cholecystitis, and it's just a simple blocking of the duct, the cystic duct in particular. So you can see where that red spot there, that's showing you where the blockage is located. So a stone is usually the cause of the blockage, although it can be sludging. And if it's blocking and if it's in that cystic duct or the neck of the gallbladder is going to be cramping, and it's going to be intermittently contracting, trying to get that stone out of there, which is why we're getting the waves of pain and it's coming and going. It's because of the cramping. Now, we need to have an elevation of the T-bili and an elevation of white blood cells on labs in order to qualify for acute cholecystitis. And if it's been going on a long time, you can perforate your gallbladder, which is kind of rare, but a side effect that you should definitely be aware of. Now, as far as signs and things that we're looking for in the history, We're going to be looking for a Murphy sign. We're going to be looking for nausea, vomiting. We're going to be looking for that intermittent crampy pain as well as fever. Now, remember, not everybody has fever because a lot of people take Tylenol or ibuprofen. So again, here's the labs. And here is the ultrasound findings that we're looking for. Here is our treatment. So within 7 days, we want to get a cholecystectomy, which means that if the surgeon says, yeah, admit him and I'll do surgery tomorrow, that's not abnormal. So they don't have to get this taken out within that first 1 to 2 days. As a matter of fact, some surgeons are finding better outcomes if they wait for that inflammation to decrease. So that way it's less hard to get off of the liver. Now, if it's been more than 7 days, typically we give IV antibiotics and we order a HIDA scan. HIDA scans happen inpatient, so that means that would require admission or referral to a GI specialist. Now, if we have biliary colic instead, it's similar symptoms, but we don't have the ultrasound findings that are usual for acute cholecystitis. Now, unfortunately, while gallstones hurt, and look, you can have so many gallstones and you can have that crampy abdominal pain because your gallbladder keeps cramping, it's not an emergency. So what I do is I tell my patients this is likely to reoccur and can very likely turn into acute cholecystitis. So I recommend going on the gallbladder diet, which involves no fried or fatty foods and no dairy. I also recommend weight loss, and I give them Toradol for pain. Now, this goes for acute cholecystitis as well. Toradol is significantly better than narcotics. You're going to notice that with all stone pain, with all of that crampy pain, we're going to use Toradol whenever possible. So if somebody has a whole lot of stones or they've been having a lot of problems with biliary colic, but they never seem to have acute cholecystitis, I always educate my patients and tell them that they need to go follow up with the surgeon for an elective cholecystectomy. That's what happened here. This is an elective cholecystectomy. And unfortunately, if the person does not have insurance, then the likelihood that they're going to be able to pay for an elective cholecystectomy is really low. So you need to have that discussion with your patients and you need to talk to them about, hey, if you have insurance, go to a surgeon and get this gallbladder out if it's causing you this much pain. In the meantime, if they develop fever or worsening pain, then they have to come back because they can develop acute cholecystitis at any time. So before we go on, we need a little talk about what does bile salt do? So bile is made by the liver. The gallbladder does not make it. It just simply stores it. Okay. So what bile does is it pretty much breaks down fat so that way we can digest fat. Okay. This is why when we're talking about gallbladder diets, we say absolutely no fats, no oils, no fried foods, because whenever you ingest fat, the bile is released. So this is a large globule of fat, and you can see that the bile is represented as these tiny little green lines. So it breaks down the fat into small little tiny drops. It's emulsifier, kind of like soap is, and it breaks all of those little oils and fats down so that way we can actually absorb them. Bile is made of a whole bunch of things, including cholesterol, phospholipids, and a bunch of bilirubin and biliverdin, as well as electrolytes and water. So cholesterol is actually helpful to break down fat. So another example of why we need to eat cholesterol, and fat-free diets don't always do well, except if you have a gallbladder problem. Now, I'm not sure if you knew, but there are different kinds and types of gallstones. There is cholesterol gallstones and pigmented gallstones. Most people have cholesterol stones, and that doesn't mean that they eat too much cholesterol. It means that the cholesterol has been sitting in the gallbladder for too long and it clumps up. That's how you develop a gallstone. Now, that said, for some reason, we also know that it is related to estrogen. So female is a risk factor for gallstones. although men can get them. We refer to these as the 5 Fs. Female, fat, fertile, 40, and fair are the risk factors for gallstones. There are also certain medications that put you at risk for gallstones, including fibrates, oral contraceptive pills, Rocephin, which is an antibiotic that we give quite a bit, and octreotide. So these are good risk factors to know in the back of your mind, something to consider every time you have a patient with right upper quadrant pain, that you need to be asking yourself these questions. Now, obviously, some risk factors are unchangeable, which is why we don't talk about them very much, right? You can't change whether you have female hormones or not. You can't change if you're in your 40s. And sometimes you can't change because it's too late if you already have diabetes or cirrhosis. So we tend to focus on the modifiable risk factors for our patients when we are asking them a lot of these questions. So things like their diet, their physical activity, they need to lose weight. We need to talk about all of these modifiable risk factors are things that we can educate patients about. Notice that rapid weight loss. So, people who are on the keto diet, for example, tended to develop a whole lot of gallstones. So, it's really important that you be aware that when we lose weight, we can't lose weight too quickly or you're going to develop your gallstones. All of that being said, this is about all the information you need to know about gallstone risk factors, unless, of course, you've got somebody with some special diseases like alcoholic cirrhosis, biliary infections, or chronic hemolysis. Those folks are the folks who can develop these pigmented stones, which are the dark, dark stones shown here. All right, so let's move on beyond gallstones. Let's talk about another patient. Go on, read it. All right. One of the things that's very similar that you're going to notice is that this pain started only hours ago. Okay. It's right upper quadrant and it's epigastric. Notice that we are having vomiting and that it is coming and going. We do have some tachycardia, but no fever. And really, this looks very similar to the previous cases that we've been talking about. So, in your differential pretty high is some kind of gallstone or biliary disease. So, here's our big differential, and here's our labs. Now, one of the things that should be particularly noteworthy here is that she does have a white count. So again, acute cholecystitis is pretty high on my list, and we do have elevated liver enzymes. Yet again, with elevated bili. So I'm thinking gallbladder, and I'm also thinking, hey, look, we've got high white count. This looks like acute cholecystitis to me. However, I also want you to notice this lab, which is one of the main differentiating factors in this disease versus other diseases, and that is that lipase is really high. So instead of this just being acute cholecystitis, we're going to get, we got a CT scan in this point, but you can see the gallstones are actually in the common bile duct. They're not in the cystic duct. And this is a pretty good indication of something called Gallstone Pancreatitis, also known as Colidocolithiasis. So this is a combination of acute cholecystitis with pancreatitis. And you can see that there's some kind of blockage down here where it's blocking both the common bile duct as well as the pancreatic duct. And you can't see the exact stone, but you can see there are stones in the common bile duct. And so that's how we know that this is what's going on. This is vomiting being very prominent because the enzymes back up into the pancreas and they cause quite a lot of nausea, and they start digesting the pancreas. This can become necrotic very quickly, and always get imaging. This is also treated by something called an ERCP or an MRCP. And because not a lot of people are very familiar with this, I want to go over quickly an ERCP. This is an E stands for endoscopy. Is usually done with a gastroenterologist with this fancy device, either in an outpatient or inpatient setting. And they put this device down your stomach into your duodenum until they find that ampulla of Vater here. And then they insert this little disc up here until they squirt a whole bunch of dye. They find the stones and then they go in and grab the stone and either break it up or pull it out. So you can see in this picture, this is the colonoscopy or endoscopy device. And what they've done is they've put a whole bunch of white contrast up here. And you can see these black, what looks like bubbles. These are all of the stones that are located in that cystic duct that are not supposed to be there. So this person's cystic duct is full of stones and they need to go in and either break them down or remove them, which can be done in an endoscopy suite, which is pretty nice. And MRCP does pretty close to the same thing, only it's an MRI essentially of the cystic duct, and we can't remove them with the MRI, obviously. All right, now let's move on to another disease. Go ahead, read it for yourself. All right, so this one again sounds pretty similar. We do have vomiting and we do have pain for about 2 days. The interesting part of this is he has got a lot of risk factors, right? He has the diabetes as a risk factor. We also see that he's on blood thinners, and that he's got this tender right upper quadrant pain that's coming and going. We also see that not only is he tachycardic, but he's got a fever this time, and his blood pressure is really soft. This makes me think that he's significantly sicker than the previous patients that we've seen. And he also has notable jaundice. So I wanted you to see what scleral icterus looks like. It's usually pretty easy to see on Caucasian or lighter colored skin, but it's also equally able to be seen on darker color skin because everybody has that nice white color in their eyes. So always look for scleral icterus. Now, in my differential, notice that I have quite a few things on here that our patient is significantly sicker with, like sepsis is one of the top things on my differential here because of how bad the patient's vital signs are and how sick he actually is. Notice that we also have some pretty significant lab findings. His white count is really high. And we also have that elevated bilirubin. We also have really high liver enzymes, although notice that the lipase is not high. So this is not gallstone pancreatitis. We also have other high labs, things like a high glucose, and that could be from sepsis. We have kidneys that are not doing too well. We have potassium that's high, and this sodium is not that impressive to me. So something is not going very good with this guy. He's not looking too good. So I'm going to order some initial fluids. I'm going to order some pain medicines, plus or minus antibiotics, right? We need to order those sooner rather than later. And I got to decide whether I'm going to order an ultrasound versus a CT scan. And for me, I'm going to order this ultrasound to start with because of the fact that he's jaundiced and he's got the fever and he's got the right upper quadrant pain. To me, this is going to sound more like a biliary problem. I'm also going to be ordering quite a few other labs that we didn't order on any of the other patients because I'm concerned about things like sepsis. And I want to make sure that I'm not cornering myself into one differential. So I'm going to order things like a urine to make sure that he doesn't have like a UTI. I also want to order cultures, make sure he's not bacteremic. I want to order an ammonia because his liver is obviously not doing very well. And then, of course, an ABG or more likely a VBG. Trying to see how acidotic this patient is. And this gentleman has acute cholangitis. Now, if you remember one of all of these different disease processes in the biliary duct system, please remember acute cholangitis. Acute cholangitis is the big kahuna. This is the one that will land you in the ICU. This is the one where patients look really sick. So acute cholangitis is an infected bile duct. Okay, so we're thinking about septic patients, maybe even shocky patients. These are patients with multiple comorbidities. Okay, we have lots of elevated labs, and we're going to require both IV antibiotics and an ERCP, as well as an ICU admission. And there are several different triads I want you to notice on this side over here. Okay, so notice that we're going to have fever with right upper quadrant abdominal pain and jaundice. That triad is one of the few triads that we do actually see in medicine, so it's worth your memorization. And if you take that exact same triad and you add confusion and hypotension, which pretty much just makes it shocky with altered mental status, that becomes Raynaud's pentad, and that is really bad. This patient is probably not going to do well, and it will need broad spectrum IV antibiotics as well as an ERCP that day. This is one of those patients that you need to transfer and you need to have on your differential every time the patient looks really sick, especially if they're jaundiced. I also want to point out kind of an interesting correlation here is that anybody with ulcerative colitis has a really high likelihood of having acute cholangitis, and nobody is really sure why that's the case. So, what causes these biliary tract infections? So, most common cause is a gallstone. And for some reason, the gallstone blocks some kind of bacteria in the system. And that's where the system is then able to cause an infection. So think about this as pyelonephritis of the gallbladder, right? So this is a lot sicker. It can also cause pancreatitis, depending on where the blockage is. And tumors can also cause cholangitis, as well as gall surgery gone wrong. That's right. So somebody can have their gallbladder out and still have acute cholangitis. They can still have the right upper quadrant pain, the elevated enzymes, all of it. So remember that just because they have had their gallbladder removed doesn't take out gall off of your differential. So please note these different triads. These are really useful clinically, and it's really useful to know this kind of diagram of the biliary structure. Now, a lot of people don't get a lot of information on cholangiocarcinoma, which is gallbladder cancer. So I wanted to kind of make one little note of it. And that is, you can get cancer anywhere. So this is a buildup of the biliary duct cells, and this is what it is. This can be something super tiny or super slight, and it builds up and eventually can cause a mechanical obstruction that can lead to cholangitis, right? And this does require cancer specialists, oncologists. While it is very rare in the US, the highest risk is for a parasite called a liver fluke. This is a liver fluke, and you can see those liver flukes inside a liver. This is something that's very common in third world countries, unfortunately, and is also something that you need to be aware of, because not every patient you're going to see is going to be from the United States. Obviously, you're probably not going to see a whole lot of liver flukes in the United States, but it is worth knowing that you can have bile duct cancer, and that can lead to cholangitis. So here are all of the 5 diseases that we went over, right? And for some reason, they differentiate gallstones with biliary colic, even though I consider these the same. So just having gallstones versus having biliary colic is the same, in my opinion, which is why it's really only 4. Now here's a quick watch review question. Now, hopefully this is pretty easy for you guys since we just went over it, but notice that this patient has a fever Okay. And as demonstrated by her vital signs, she's also pretty tachycardic with a very soft blood pressure, which is very scary. That's somebody who is sick. Notice that she's also got some jaundice here and right upper quadrant pain. So already we're working our way through the pentad. We have jaundice, right upper quadrant pain, and we've got a fever. Plus, we're notably confused and we have hypotension. We have the entire Raynaud's pentad here, which means that we have cholangitis. So it's really important to note that this is easily tested on, as well as something that is found frequently in the clinic. So please be aware, cholangitis is the one diagnosis that you need to know. Now, before we go on, that's all we're going to talk about biliary diseases, but one of the big organs in your right upper quadrant is obviously your liver. And I'd like to talk for a minute in the basics on what your liver does, because we can't talk about liver labs unless you know what the liver does. Now, this is pretty much an oversimplification, and I do apologize to any GI docs out there. But the kindergarten version here is that your liver's job is to clean toxins out of the blood, process all of the absorbed nutrients from your intestine. If needed, it can make gluconeogenesis, right, for the brain. It also makes albumin. It helps us waste our nitrogen, and it helps with clotting factors. So if we have a problem with the liver, one of the first places that we're going to see problems is we're not going to clot very well. And we can have buildup of toxins in the blood, and we can have our albumin go down very low, which means that we can have an increase of swelling. Notice that we won't be able to take fasting very good because we can't do gluconeogenesis. And we might have some malabsorption problems because even if we absorb the food in our intestines, we can't process it. So if you know what the liver does, then you understand what liver failure looks like, which is really handy when we talk about our liver labs. So there are quite a few liver labs, and liver labs are the main difference between a basic metabolic profile and a complete metabolic profile, right? The only difference between the two is whether you want liver labs or not. Now, notice I've also included quite a few other things that are not included in your complete metabolic panel, such as your coags or your ammonia. Those are special labs that you have to order separately. However, AST and ALT, which we're going to talk about all of these individually, are primarily showing us acute, so notice not chronic, acute hepatocellular damage, those cells that are being damaged right now. ALK-Phos is made in the liver as well as multiple other places, and so it can be elevated when we have liver problems. We also have our bilirubin, which you know is made by the liver, and then our albumin, which is also made in the liver. Our coags are our first abnormal thing to go wrong. So if your liver is in trouble, your true function test is getting coags and seeing if the coags are malfunctioning. And then your ammonia. Your ammonia is that nitrogen waste product that the liver should be filtering. When it's not filtering, we have a problem. So let's talk about what jaundice is. So jaundice is obviously a physical exam finding of the skin. And the very first place that you will be able to see it is under the tongue, like this picture is showing you. Right? You can also see it in the cheek and on the soft palate, as well as in the eyes. Okay. So if you have somebody who's maybe darker skinned or somebody who you can't quite tell, are they yellow, are they not? My first recommendation is to always look underneath the tongue and look at the soft palate. Those should be two areas where if you see yellow, this person is jaundiced. Now, there have been a couple of cases of people who just have scleral icterus only. We'll talk about that a little bit later. But jaundice is only caused by one reason and one reason alone, and that is elevated bilirubin. Usually, this is an indication of a liver problem. And again, we'll talk about that here in the next couple slides. But bilirubin accumulation is very itchy. And so, if you have a patient who's presenting for extreme itching, that should be something that you should look for underneath their tongue. I also want to go ahead and make sure that everybody knows that if somebody has painless jaundice and they're like, I feel just fine, I don't know why I'm yellow, you need to think about liver cancer until proven otherwise, because it's almost always liver cancer and you got to play by the statistical significance, right? So let's talk about this bilirubin stuff. So when you're investigating somebody for jaundice or for liver problems, there are three big lab values. You have a total bilirubin, which is usually what comes on your complete metabolic panel. Then you can order special, the conjugated and unconjugated bilirubin. Okay. You also want to ask a couple of very personal questions, which is the fact that bilirubin gives poop its brown color. So if you have somebody who's not conjugating their bilirubin, you can get these clay colored gray stools. And you can also get these really dark urine. This really dark urine is very common in cirrhosis patients. Notice that this is in comparison to the normal colored urine versus very dark tea-colored urine. That is because your body is trying to get rid of some of that bilirubin that's not being filtered by the liver. And so it's being peed out by the kidney instead. So there are lots of different signs and symptoms that you can look for that can give you clues that there's a problem with the bilirubin. Okay, so let me talk for just a brief instance on the bilirubin here. So we have our heme group, or our red blood cell right here, and we have our albumin floating in the blood, right? And what's going to happen is our red blood cell dies and our heme group is going to bind to our albumin, and it's going to be our indirect or unconjugated bilirubin. So it doesn't really like water, and it's hard to move around the blood, which is why it has to attach to our albumin. Okay. And then it gets to the liver where it becomes water soluble. That's when it gets conjugated and it becomes our direct bilirubin, right? That's a direct output of our liver. So if we have a problem with our indirect or unconjugated bilirubin, think about problems that have nothing to do with the liver. For example, we have hemolytic anemia, where too many heme groups are breaking down and they can't be bound to the albumin to get to the liver because there's just too many. Another option is that we're just not conjugating we're not combining it with the albumin enough. Like we don't have as good blood flow, like in congestive heart failure or in Gilbert's disease. Usually an indirect problem with bilirubin is a positive problem because it's something that isn't as life-threatening as maybe the other problems can be. So when we have a direct or a conjugated problem, usually it's a biliary duct obstruction problem or it's a big liver injury. Like, for example, you have hepatitis, or you have some kind of liver infection, or maybe you have alcohol intoxication, or maybe you have cholangitis, et cetera, et cetera, et cetera. Okay, now let's talk for a second about ALK Phos. ALK Phos, remember, comes from the cells of the bile ducts, but it also comes from bone and placenta, which means that ALK Phos can be high in lots of other problems. For example, if you have a bone problem, like you have metastatic cancer, or you have a healing fracture, or even if you're growing because you're a child, your ALK Phos can be high without having a high liver enzyme. Right? Notice that if you have a high ALK Phos, your pathway should be to look at the liver enzymes, right? So if you have normal liver enzymes, you could have a bone problem, or you could have non-bone problems, things like cancer, things like thyroid or parathyroid issues, or you could have failure of blood flow, like renal failure or heart failure, where albumin is really the issue, right? Now, if we have high liver enzymes, then we need to think about problems with the common bile duct, right? So we have either a gallstone, or we could have gallstone pancreatitis. We could have a pancreas pseudocyst, a parasite, or we could have just had surgery. Maybe we have chemotherapy, right? There's a lot of different options there. If we have a normal common bile duct, right, that's done on the ultrasound, we could have problems like hepatitis or sarcoidosis or primary biliary cirrhosis. And we'll talk a lot about those later. Notice that you can also have pregnancy, right? Because it's made by the placenta, which isn't in this chart. That can be a reason why your ALK phos is high. You can also have a growth spurt, or you could have just vomited. That can cause your ALK phos to be high also. So ALK phos is pretty non-specific, but it's really good to note that we're going to look in places of bone, places of liver, and places of pregnancy. Now let's talk about your AST and ALT specifically. Think about these as the troponin of the liver, okay? So this is about acute liver injury. If those cells are being injured right now, then your AST and ALT are going to be high, which means that if you're acutely drunk right now, because this lecture is really getting to you, your AST and ALT will temporarily be high because alcohol temporarily causes liver damage, okay? That also means that they can burn out, which means that if you have a patient with cirrhosis, your AST and ALT can be normal or even low. And that's because it is not acute, right? So it's important for you to know that AST and ALT, the A means acute. Now, let me talk to you quickly about some alcoholic damage, and that is something that I learned in medical school. I learned the phrase straight liquor, and that is, if you look at the difference in the ratio, straight comes before liquor, so that means your AST will be higher than your ALT if the problem is caused by alcohol. So let me say that again. Straight liquor will help you determine the order that S or AST is bigger than ALT, usually in a ratio of 2-to-1 or 3-to-1, and that's only because of alcohol. So this can be really helpful, because if that's not the case, then you know that there is some other kind of problem, maybe something like hepatitis or a liver, or like a Tylenol overdose or an autoimmune problem, something else, right? If we're going to talk specifically about what they are, ALT is significantly more specific for liver. AST is a little bit less specific. So that means it's a lot more common for AST to be high. It can have problems with red blood cells, heart, muscle. It can be around the liver. It can be pancreas. It can be kidney. It can be brain. There's a lot less specificity with the S. But the S is going to be significantly bigger with alcohol, because alcohol does a lot of damage, right? If you're interested in dividing AST over ALT, then here's something that you can do a quick calculation of. And if it's over 5 times the normal, then this is your differential. 5 to 10, this is your differential, and over 10, this is your differential. Another way I like to know this is something that I call shock liver. So if your AST and ALT are over 1,000, we're very freaking close. This is somebody who's in shock liver, and shock liver patients should never go home. This is severe liver damage. They're in the midst of having liver failure acutely, and they need to be admitted. We need to find the cause of their liver problems, and it can be a long list. So there's a lot of things that we could do. One of them is HELP syndrome. If the patient is pregnant, they could have a Tylenol or a mushroom overdose. They could have severe rhabdomyolysis, which is another thing that can cause shock liver. But many, many other things can cause shock liver, including heart failure or hepatitis or Wilson's disease. There's many. But important for you to know that if your liver enzymes are over 1,000, this is an scary situation. Okay. Now let's talk a little bit about ammonia. Ammonia can be high with liver cirrhosis, but it doesn't have to be. It is not a diagnostic tool. So think of it like the pro-BNP for heart failure. So pro-BNP can be high in many other things. For example, somebody who's fluid overloaded because they haven't had dialysis. So ammonia doesn't have to be elevated for somebody to have really significant cirrhosis. However, when it is elevated, it causes confusion and hepatic encephalopathy. Okay, too high of any kind of nitrogen waste product has bad effects on the brain. So when you think ammonia, you think brain. So if the nurse comes in to talk to you and you have a known liver patient who has liver cirrhosis and they are not confused or altered in any way, and the nurse says, "Do you want an ammonia level?" Your answer is going to be no, because if they're not confused, they don't need an ammonia level. Most cirrhosis patients do not need an ammonia level unless this is a workup for a brand new cirrhosis. Okay. It is also the marker of a generalized decline, although it does not correlate with how bad the cirrhosis is. So you could have somebody with terrible, terrible cirrhosis who does not have an elevated ammonia level because it hasn't gotten to that point. Okay. So think about muscle breakdown leading to problems with the liver, and it's excreted in the kidney and stool. Okay. And the main way that we treat this high ammonia level is we give them oral. So this cannot be IV, oral lactulose, which causes diarrhea and forces your body to poop it out. So lactulose will cause diarrhea. So if the patient's coming in saying my medicine is causing diarrhea, the answer is, well, yeah, duh, that's what it does. Okay. All right. Now let's talk just a quick minute about some liver pathology here. I want to go ahead and say that as far as all the different hepatitises are in the emergency department, and this is a giant list of them, I'm not going to go into crazy detail about these. While these are favorites of most test questioners, in the emergency departments, it's important that you know that hepatitises can cause fevers and that they can cause abnormal liver enzymes. And that if you're suspicious of a hepatitis, you should always admit the patient. However, these are not going to be diagnosed in the ER. As a matter of fact, most of these tests take a couple of days to come back. So the differentiation of hepatitis is not really an ER diagnosis. It's something you can have on your differential. It's something you can even start for internal medicine if you think that needs to start, but it is not something that is done in the emergency department. It's not completed. So I don't think it's worth your time to go through all of the differences. You're welcome. Now let's talk about the process of cirrhosis. So just like with heart failure, liver failure is a spectrum. Notice that you go from a healthy liver to a fatty liver to NASH to cirrhosis. Okay, this doesn't happen in 1 month or 2 months or 3 months. This doesn't happen because occasionally you get blackout drunk on the weekends. This is solid chronic damage to your liver for years. Okay, usually and often cirrhosis is an alcohol thing, but it can be caused by other problems. And we spend a lot of time talking about cirrhosis, which we're going to do in the next slide. But I want to take a minute and talk about fatty liver and NASH. Fatty liver and NASH can be caused by your diet, by prediabetes, or it can be caused by an abnormality in your genetics. Okay, so fatty liver and NASH can often be fixed, aka completely reversed, with fasting and certain medications. Fatty liver and NASH can also cause pain due to stretching of the ligaments, especially this main ligament located right here, right? So if you have right upper quadrant pain and nothing shows up in the labs and nothing shows up on your CT scan except for fatty liver, there is a possibility that fatty liver can be the cause of the pain. It can be good to recommend to your patient with new onset fatty livers that they should consider fasting and should follow up with a liver specialist, especially because they're on the spectrum for cirrhosis, and we want to prevent that if we can. Now let's talk about what you need to know for cirrhosis in the emergency department. And that is the most common cause of cirrhosis is alcoholic problems. And again, I'm telling you, this is a long-term problem. This is years of alcohol problems. And it is getting more and more common for young people in their late 20s, early 30s to have cirrhosis because they are hitting it hard and hard and hard and hard. So you should be impressed if somebody has a alcoholic liver problem of cirrhosis in the emergency department. The second most common cause of cirrhosis is hepatitis C. So again, if you're having somebody who has a patient with cirrhosis and it's new onset, you should ask these two questions. You also need to be aware that cirrhosis patients, if they're coming into you in the emergency department with already that diagnosis, watch out for bleeding problems, watch out for prolonged drug potency, which means that we might need to dose them in lower doses for things like benzos, things like narcotics, things like certain anticoagulation. You also need to think about esophageal variceal, especially if we have alcoholic patients. And you need to consider the fact that if they have ascites, which almost all cirrhosis patients are going to get, could they have spontaneous bacteremia? And do they need a diagnostic or therapeutic paracentesis? So, those are something that you should always consider. We can talk a whole lot more about this later, but remember that if you understand what the liver does on at least a kindergarten level, then you'll understand what liver cirrhosis patients look like. Now we have to have a moment of clarity on Tylenol overdose because of all the toxicology stuff that you're going to learn about. Tylenol overdose is something that you will see. It is very common. And it is a combination drug in many of the over-the-counter medications, as well as Norco and Percocet and many, many other medications. You know, think about Tylenol number 3, right? A lot of times patients don't know the difference, and they don't know that acetaminophen is the same as Tylenol. So it is important for you to know that and for you to always screen whenever you think about it. Of all the stuff that you need to know, we're going to go over this in the toxicology lecture ad nauseum, but you should know that you can have an acute or a chronic ingestion, and that 140 is the magic number to know because 140 is the toxic dose. It's also the likely liver toxicity at 4 hours, and it is the first dose of the antidote. So 140 is the magic number when you think of Tylenol overdoses. It's also important for you to know that getting a Tylenol level, even within the first 3 hours of Tylenol ingestion, are going to be negative. It takes 4 hours for that Tylenol level to be accurate. So the nomogram that you can Google determine whether or not somebody is in toxicity is useless before 4 hours. Notice that there is no data because you have not completely absorbed it. So you literally should not get the Tylenol level until 4 hours after the ingestion of whatever medication that they have claimed to have taken. All right. There are 4 different stages of Tylenol overdose. And one of the most important things I want you to know about is that most people with Tylenol overdose for the first 24 hours are going to feel mostly fine. They might have some nausea and vomiting and belly pain, but really nothing is going to show up in the labs until after day 2. In day 2, their AST and ALT start to rise. We're also going to see they're going to have coagulopathy problems. However, they're going to be asymptomatic. And this is called the quiescent phase, this stage 2. So somebody ingests a whole bunch of meds, they feel nauseous, and then they get better. They think they're doing fine on day 2 and 3 until suddenly they come in with confusion and gross liver failure. And it's too late because they're going to either die or get better. And by getting better, it means that hopefully they've got to us by this stage and we've given them the antidote, right? Very few people who don't get the antidote survive. So we call this almost completely a fatal situation. Tylenol overdoses are a really terrible way to go. It's very painful. And a lot of parents who present with their kid who has overdosed on Tylenol come in and they don't believe you because they're like, the kid's not hurting and they're not throwing up. And I don't understand why you're telling me that the kid could die in 4 days. And it's a really complicated situation. If you want to know more about this, we're going to be talking a whole lot about it with a bunch of example cases in toxicology. So look forward to that lecture soon. I also have to bring up that if your patient is pregnant, you need to consider HELP syndrome. If you've forgotten what HELP syndrome stands for, it's the exact definition of the problem. It's hemolysis with elevated liver enzymes and low platelets. Okay. And so you need to get labs whenever you have a pregnant patient who has right upper quadrant pain. It could be gallstones, but it could also be something more serious. So your biggest problem with this is going to be to recognize that this is what's going on. It's also something that needs admission, so do not send a HELP patient home. Always transfer or get them to an OB sooner rather than later. It doesn't matter how many weeks pregnant they are. Usually this is going to be in the 2nd or the 3rd trimester, but it is something that you need to admit and have an OB seen for, okay? And finally, we're going to talk about Fitzhugh-Curtis syndrome. So this is a female-only disease because those fallopian tubes do not completely close off the pelvic area. So if she has PID or some other STD, those bacteria can float out of the fallopian tube and into the bowels, and they can actually get to the liver. So Fitzhugh-Curtis syndrome is basically gonorrhea in the liver. So again, it's females only, usually younger, and it will be fatal without treatment. And they will present with right upper quadrant pain, and then they will also have PID along with it. This will definitely develop scarring of the liver and requires IV antibiotics and admission. If you happen to be somebody who has seen one of these cases, please comment below because I have yet not. So here's the summary of all the different biliary tract conditions that we talked about. Here is an example of all the different biliary tract diseases in a different form in case you're a chart person. Here is a little reminder of all the different liver labs and what they stand for. And if you guys have any questions or comments, I look at all of the comments below. And until next time.